record on this computer.
Well, hello. Can everybody see me? I don't think you can see my hair.
Yeah.
It's in there.
Because of the
somewhere.
blonde background.
Anyway, hello. Welcome to the September meeting of the Georgetown area DBS support group. We are under the umbrella of the Georgetown area Parkinson's support group. And we'll talk about that in just a minute. Okay, the dog's gonna cry. Okay. Our mantra is ask questions, seek answers, and make friends. And that's what we're going to do today. Ask questions, seek answers, and make friends. Mary Jane and I, where's Mary Jane? Oh, there she is. We went to a workshop a couple of weeks ago that was for support group leaders. And it was a very interesting workshop that was put on by PMDA, which is the Parkinson's and Motion Disorder Alliance. Very good organization, has all kinds of information, a lot of speakers, a lot of workshops, a lot of support groups. Mary Jane's phone is ringing. And but it was interesting. The main emphasis of the workshop was joy, happiness, gratitude, friends, connections, uplifting thoughts. Very little about how to conduct a meeting, but a lot on sharing joy. So I've decided that we should share jokes. Now, I need jokes. Please email me your jokes. If you have a good joke, clean but funny, send me your joke. And I have one. Okay, you ready? This is my only joke. Just a minute. What do you call a fish with no feet? What? A fish. So you got a joke? Uh-oh.
37.
Y'all have heard that one. 37? It's the one about the guys in prison sitting around a circle and they've been there for years together. And instead of telling jokes, they just say the number. Okay. A little bit of housekeeping. I think everybody has signed the list. You should have name tags on. I'm sorry. Bathrooms down the hall, right over here. And part of our housekeeping is that the GADS meeting is tomorrow, September 22nd, here at the Baptist Church in the gym. And Queen Mary Ann's going to come tell us a little bit about it. I say queen because she's not a king. And okay.
And it's Mary Jane.
Did I say Mary Jane?
Mary Ann.
I said, oh.
It's not a problem. Anyway, hi, everybody. Hello, Zoom crowd. Okay, tomorrow is our Parkinson meeting. It's going to be here, just as she said, at the gym here at the First Baptist Church. Please come. We're also going to have a flu shot and COVID clinic. So if you would like to get your flu shots or your COVID shots or any shots, just call the pharmacy. All that information is in my email. And if you did not get the email, feel free to call me and I can give you the connections. And that's going to be with Liberty Pharmacy. And yes, they do accept Medicare. So it's all covered under Medicare. We're also going to have a Medicare specialist. So if anybody needs to check out their Medicare, or if they got different Medicare plans, we will have a Medicare specialist here from the state. So it's not going to be anybody selling you anything. It's going to be strictly to learn about Medicare. And that'll be a sub table. We'll have refreshments. But with all of that said, the speaker tomorrow is going to be on the Parkinson mind. The Parkinson mind. It's going to be very, very good. And that is, we always meet the fourth Thursday of every month, 2:30 social, 3 o'clock the meeting. Thank you, Judy. Okay.
Thank you, Mary Jane. Sorry about that. Okay. Now we're supposed to be stressing connections. And one of the connections that I would like to stress today is the fact that in our group of the Parkinson's movement disorder family, we have a lady that makes jewelry. And her name is, I think we should shut that door. Her name is Kat Lundy, and she's having a sale at her home on October the 29th, and I'm going to pass out some information about that. Now, this sale is for real jewelry. I mean, the kind you keep forever. So I really enjoy being with her. At her open house, she has lots of good food. Last year, I just went for the food. This year, I'm going to buy something. So I will pass that out. It's October the 29th. And like I said, we want to support our Parkinson's community, our Parkinson's family. So that's part of our connections, is to help out there. Another one is, we have 3 providers for DBS. We have Medtronic, Abbott, and Boston Scientific. And I have a flyer that I want to pass out concerning information that you can get from all 3 of those. Now, the lunch and learns are specifically spelled out and what the date is and the location and the time. And then Boston has 6 webinars that are currently available online from DBS and me. And that's all written down here, so you can check that out. Okay, now.
And it's on your webpage.
And it's on the webpage, right? Another thing I want to mention is that we do have a new logo. And y'all might remember the kind of the purple man with the spark in his brain. He's gone. No more. So now our logo looks very much like the Georgetown Area Parkinson's Support Group logo, but it says DBS support next to it. So don't look for that purple man with the spark anymore. He's gone. Okay, now I'd like to introduce our speaker. And Meredith Hatcher and I have known each other for quite a few years. Well, at least 5 years, right? And Meredith grew up in Allen, Texas. Now, I got to tell you a bit about Allen, Texas. Allen, Texas is dear to my heart, not because of DBS or Parkinson's or anything else. It's because of Habitat for Humanity. Now, this is an interesting story because Sid and I were in a club called the Rambling Builders, and we had a motorhome, and we would go about twice a year to different places all over the United States and build houses with Habitat for Humanity. And you'd be amazed what old people can do. But yeah, I can make one to seals. The honey, pet the dog, please. But the most coveted build of all was in Allen, Texas. I don't know why, but people wanted to go to Allen to build houses. It was just amazing. So much that the minute that bill came online, it was filled and we never got to go. Yeah. So that broke my heart, but that's all I know about Allen. Yeah. Okay, so Meredith went to university here, Southwestern. Whoa. And there she played NCAA volleyball for 4 years. Really? And she was a member of a sorority, Sigma Phi Lambda.
It's a Christian sorority.
Christian sorority. And then she went on to Nashville, Tennessee to get her master's of science in medicine. And after that, she joined Dr. Swallow and became trained under his tutelage in DBS programming and Parkinson's, everything. I'll hold her in a minute. So Meredith's going to speak to us today on DBS and everything non-surgical. And she's promised me that she can answer any question that you have, no matter what it is. You know, ask her what size shoes she wears and she'll tell you. Okay. With that, I would like to introduce Meredith.
Thank you, Judy. Thank you. Lots of familiar faces. I know a lot of y'all, and we've got some awesome reps. We've got Candace and Aaron over there joining too. So I'm sure they can help answer a lot of questions too. Candace with Medtronic and Aaron with Boston. So lots of good people, and hi to everyone on Zoom. I recognize some names there too. So I'll try to, it will pop up and show me questions. Okay, so I'll try to watch for questions here too, but I want this to be interactive. It's way better if y'all ask questions as we go. I don't want to put anybody to sleep, so feel free to stop me as we go, okay? Okay, Mary Jane, let's see. We want to,
Share screen. There you go. Green button.
oh, right there. And
and
then
go
this
to-
one,
The one that's opened up already. I think it's the second one over. That one.
this one.
Yeah. Nope, that wasn't yours. Sorry, no problem.
Stop
Okay,
share.
Yeah, stop share.
It was probably that second one. then.
Yeah, okay.
This one. That's the PowerPoint.
There
Yeah.
you go. And then,
Okay,
okay, you're officially
there
on.
we are.
And let me make sure you're on, you're still spotlighted.
Okay.
What?
Oh, no. Y'all can still see the PowerPoint, but
Restart screen is it? Okay, so I'm gonna let you talk. I'll get it going for you. Sorry,
no,
sorry.
that's okay. I'll move out of your
I don't
way.
know what on earth happened there.
Yeah, so just for those, I think I know most of y'all in here, but
I think
for
it's,
Demons with Abbott, so now we've got everybody. So for those of y'all that don't know, I work at Texas Movement Disorder Specialist. I'm a PA. I work with Dr. Swallow, and Kinsey is our other PA there. So we've got the three of us as a team. And I've been there about 5 years now, which is hard to believe. Time just flies. So but we'll go through kind of the basic process for DBS, kind of when I see patients in clinic, what are the things that we talk through? What are the questions we commonly get? And we'll talk through the steps going through the surgical process too.
I want to make sure we're still recording. We're still recording. Everything's perfect.
Okay.
Yeah, everything's gonna be perfect.
And then share screen again.
We had it, I just wanted to double check that we were recording, we were recording and we are. There you are, there you are,
Okay,
there you go.
perfect. Thank you.
Okay,
Okay, let's see. So we're starting out just with some videos. I think videos speak 1,000 words. So this is one of our patients with essential tremor, just to give y'all some background on her. Both of these videos, when they first start, her DBS is off. So you'll see a tremor, and then halfway through, you'll see her kind of nod. I'll show you when. And as it comes on, it takes about 8 seconds. Then her tremor will slow down. Okay, so she was actually a nurse, and she loved to show videos to her patients to see the difference. So definitely more in her right hand. She's also got a head tremor, which is a little bit hard to see here, but you'll be able to see it in the other one. So still off. Okay, so now it's going on. It'll take about 8 seconds. That tremor's gone away. Pretty amazing. Okay, I'll show you the other one. The other one is just so you can see her head tremor more. You can see her walking. So a lot of head tremor. You can see her hands and her arms shake a little bit too. Just overall looks kind of unsteady though. She's got tremor in her legs and her whole body. Still off. She doesn't turn it on until she gets back. So it's going to turn back on. Again, it'll take about 8 seconds. You want to turn the light on? Okay. Is that okay? Perfect. So it's back on. That head tremor is calmed down. She can walk a lot smoother. No hand or arm tremor. Pretty drastic difference for her. Of course, every patient's different. Every case is different, but I think it's always pretty neat to get to see videos yourself and see what a difference it can make for some people. Okay. All right, so this is something we really try to focus on. I know this is small for y'all. Can y'all see it okay? Okay, I'll talk through it too. But this is something we really try to focus on in clinic too, is setting expectations well ahead of time before you've even committed to DBS. So we really want to make sure that you're a good candidate for it. It's a great therapy for the right person. And part of that is understanding for Parkinson's and essential tremor, it's not a cure. It won't necessarily take away all of your symptoms. That's not the goal. The goal is to reduce quite a bit, especially things like tremor. For Parkinson's, it also helps with slowness and stiffness. Anything that gets better with levodopa, those things tend to get better with DBS for Parkinson's patients. The exception there is sometimes tremor can be a little bit stubborn to treatment. So even if the tremor doesn't respond to carbidopa levodopa, DBS can still help that quite a bit. I don't think we have any dystonia folks today, but if we're talking to somebody with generalized or cervical dystonia, the studies range quite a bit, but it's somewhere between 50 to 75% of the time we can see improvement. So not quite as successful some of the time as essential tremor or Parkinson's, but without a doubt, we still see improvement over time. Any questions about, yes, go ahead. Good question. Yeah, so there's several different types. There's cervical dystonia. You can have it generalized dystonia, could be focal in the hand, like a writer's cramp. You can have it in your voice. With Parkinson's, we tend to see wearing off dystonia. So like hand cramping and curling, the toes curling and cramping overnight, first thing in the morning. That's the classic, but it can look different for every person. Does that answer your question?
Yeah.
Okay, cervical dystonia can be completely unrelated to Parkinson's too. We see it most often middle-aged women. It just comes on sporadically and there's not necessarily a cause for it. That could be a little bit of a dystonia too. So it could respond. And I know you mentioned they were thinking GPI for you. So we'll get into targets in the brain in a little bit, but. Oh, sure. Sure. The question was his hand spread some on him and he's asking if DBS will help with that. And sometimes the GPI target for Parkinson's, that can help even more so with dystonia. So that could help. Same with dyskinesia. It can be a little bit more helpful for dyskinesia. Any other questions? Didn't see any pop up on here. I'm not sure it would show me though if the chat's not necessarily open, but I can check at the end too and make sure we get to all of them. Okay, so yeah, bottom line is just discuss with your healthcare team if you are a good candidate. Okay, so you've decided that you are interested in DBS and you want to move forward. Here are the steps in the process. So first thing we do for Parkinson's is neuropsych testing. That's just really thorough cognitive testing, takes a couple of hours, it's in depth, and that's just to make sure you're a good candidate. So if we have gotten to where we have mood disorders, extreme mood disorders, or we have cognitive decline to the part where we're having dementia, typically that means we can't do DBS anymore for a Parkinson's patient. The main reason for that is DBS is pretty involved. You have to be able to report your symptoms. The anesthesia may affect you a little bit more if someone has dementia. So we are careful about that. And when you hear us talking about a window of opportunity, that's what we're referring to. I'll talk about it. I've got a whole slide on neuropsych testing, but that's why that's important. And then if we're doing essential tremor DBS, you don't need that neuropsych testing most of the time. So the second step after we've had that testing done is referral to neurosurgery. And typically once you meet with them, you can get the surgery scheduled fairly soon after that, within the next couple months. The first step is having a brain MRI, and that's usually about a week before the surgery itself. They actually use that to help plan the trajectory ahead of time. So it helps kind of smooth up the process a little. So that's first step. That's all arranged by the neurosurgeon's office. Second step would be stage 1 of the surgery itself. That's when they implant the leads, one on each side of the brain. That takes a couple of hours, 3-4 hours, somewhere in that range. Usually we stay in the hospital one night just for monitoring. And the surgery itself can vary a little bit, that whether you have it done awake or asleep, that just depends on the surgeon and your preferences. So that can be something that's discussed. Stage 2 will be about 5 to 7 days later. That's when they'll be placing the battery, usually in your chest, sometimes your belly, completely up to y'all, it's your preference. But most of the time they do the chest. if you have a pacemaker or they're worried about that, they may do the right side. We're also in Texas. If we have hunters, then that may be a reason to put it down here. So I know that sounds funny, but if you shoot a lot, you don't want to put it in your right chest. So just things to think about on the location of the battery. But the surgery to have the battery placed a lot quicker. It's a day surgery, go home same day. Some people are a little tender from that just because you're disrupting some more tissue there, but pretty straightforward on that one. About 1 month after the first surgery, stage 1, we'll schedule your initial programming, and that is back at your neurologist's office. That takes about 1.5 hours or so. That's the first time we turn the device on. That's when we'll start making medication adjustments too, usually at that point. I'll dig into a lot more on the initial programming here in a second. But any questions about the process thus far?
Do you take medication once the surgery starts to the time that you
Good
get
question.
programmed? You take your meds in between?
Yes. So the question is, in between the surgery and the initial programming, do you still take medications? And the answer is yes. You'll still take medications just as you normally would during that time. Sometimes though, the reason we wait a month, when you have the surgery, you can actually have what's called a lesion effect. Just by placing the leads in there, we actually will see improvement in symptoms. Tremor can get better, Parkinsonism can get better temporarily. And then over the next couple of weeks, that will go away over time. That's why we wait, so we're not kind of chasing that benefit as we're starting to program.
Meredith, when you have the MRI, is that under some kind of sedation?
Not usually. It depends on the person though. If you have a lot of tremor, then they can give you something. Sometimes we'll prescribe Ativan if somebody's going to have a hard time staying still, but usually not. Good question. Anything else y'all can think of for right now? Okay, we'll keep going. So I promised more on the neuropsych testing. I think I already covered some of it. But we talked about how there's that window of opportunity. We can't wait too late. What happens some of the time, and this is heartbreaking, we'll have patients referred to us after they've had Parkinson's for 20 years, and they were told DBS is a last resort. At that point, they have dementia, they have hallucinations, they are no longer candidates. We should have seen them 10 years ago. And so we really try to push that even from the first visit and explain to everyone, we do have this window of opportunity. We have to wait until we know for sure it's Parkinson's and you're levodopa responsive. You get improvement with carbidopa levodopa, but we don't want to necessarily wait too long and then it's too late. So we do have that window. Yes, Erin.
So if I somebody had asked me to bring some additional. Well, I'm gonna send you back your log on, but I feel not because it doesn't go away, but maybe because they're reduced. But now I'm understanding, and to your point, what you just said, and not everyone gets it, but there's an actual Parkinson's hallucination, even in the absence of different.
Correct. There can be, yeah. So I'll repeat the question for y'all on Zoom. The question was, the thought was that most hallucinations come from medications like dopamine agonists. And the question that Erin had got was whether they would go away after DBS. But a lot of the times they are medication induced. So that could be, like pramipexole, ropinirole, some of those can cause hallucinations. Amantadine is another one. They're still used, but over time we can see hallucinations. If we come off of them, a lot of times the hallucinations will improve, but over time, especially if dementia creeps in, we can still see hallucinations as a part of the disease. Not everyone has them, so not to scare everyone here. It's definitely not everyone, but for some people they can. Part of the trouble we run into too is sometimes carbidopa levodopa, higher doses can contribute to hallucinations. But of course, patients need that. So it's a balance. That is where DBS can help though, is you can usually, and we'll talk about this too, we can usually cut down on medications. So just kind of secondarily, because you are cutting down on medicines, they can reduce. Although if they're having hallucinations, then they probably wouldn't, we would have to talk about candidacy if they're already having them. So
Are the
a little more depth.
hallucinations you're talking about now different than the sleep disorder?
Yes, good question. So the question is, are hallucinations we're talking about different than a sleep disorder? They are. So the sleep disorder is called REM sleep disorder. That's acting out dreams, punching and kicking. Usually we hear about it from spouses, right? So people getting punched and getting kicked as you're running a marathon. So that is completely different. You're in a deep sleep. You're not aware it's happening. Hallucinations are while we are wide awake and we're talking, you see a dog in the corner, something like that. So they're very different. Good question. Anything else y'all can think of right now? Okay. The only other, let's see, we do need to talk about the targets here. So with Parkinson's disease, we have 2 targets that we implant, and that's a whole conversation on its own on the different targets. But historically, one target over the other was thought to be a little bit better for if somebody does have some mild cognitive change. And so you'll see that mentioned here, the STN, the subthalamic nucleus, versus the GPI, globus pallidus internus. GPI has been thought to be a little bit better cognitively. From when I've read about this recently, that's been a little bit more debated. There's a lot of thought on that, but overall, it seems like as a direct result of DBS, cognitive decline is fairly rare. It's more maybe related to the disease itself or medications if people are having hallucinations. Other questions about that? The targets, I know that STN, GPI, that's a whole conversation in itself. So feel free to ask me questions about that later. Okay, so initial programming. I know this is kind of hard to see here. This is an Abbott off of their website, but just helps kind of visualize what I'll be talking about. So essentially, when you come in for essential tremor, you can take your medications as you normally would that day. For Parkinson's, though, we have you come off of your medicine, specifically carbidopa-levodopa. And that's so we have you on a blank slate, completely off. And we will turn on one contact at a time. So we'll start at the very bottom. We increase the stimulation until we get benefit. And then we keep going from there until we hit a ceiling. And that could be maybe speech is slurred. It could be your vision. It could be we see facial pulling. It could be a variety of different things, or tingling that doesn't go away. We consider that our ceiling. That just means how much wiggle room do we have on that contact. And then we'll go to the next one. We do the exact same thing. And then the next one. And so that helps us determine which of the 4 contacts on each side has the best benefit for your symptoms and also has plenty of adjustment room with few side effects. Okay, so that whole process, we do one side at a time. That takes about an hour, depends on the person, but about an hour. And I think one of the most important things to remember, this is just a starting point. Programming, we do our best to get it perfect up front. That's always my goal. But often we're making medicine changes to that day. So as you can imagine, if your dopamine goes down, or for essential tremor, we start pulling back your medications, you'll have to make DBS adjustments as you go. So we think of it as a process over a couple weeks to months.
I know that reflected Abbott, but do the other Boston Scientific and Medtronic, or do they also have the 4 contacts?
Good question. Yes. So all 3 systems, they all have 4 contacts. They all have directional programming. Directional meaning, see how these middle 2, and y'all can't see this here. I'll point this out here. These middle 2, whoops, let me go back. These middle 2 contacts right here are broken out into 3. So that's showing you that you can point the stimulation certain directions in the brain. Okay, so when that becomes important, I'll talk about this again on another slide, but that becomes important if we're trying to avoid side effects like the speech or balance. We can turn off the stimulation pointing to the part of the brain that may affect that. So that's been a huge help when we're programming for sure. And they all 3 have that. Yes, Sid.
It's an important thing to point to make, that expectations from the Senate.
Mhm.
Expect too much, but you want to.
Agree completely. Yes.
Repeat it.
Yes. So Sid was saying that it's really important to set up good expectations, because if you don't have the right expectations, you think it's going to be perfect, then people will be disappointed. They won't do as well. So definitely important to set up good expectations ahead of time and kind of know what to expect. Any other questions? Yeah, Judy.
Can you predict what side effects you might have?
Good question. Yeah. So the question is, can you predict what side effects you'll have? You can some. Each target of the brain has different side effects. So for example, for essential tremor, you may see a little bit more slurring of speech, maybe. For some of the others, if you're on the deeper contacts, maybe a little bit more slurring. And so it can depend on what part of the brain you're in, which direction you're pointing, where you're at, how deep you are. And one of the newer things too is that and I have this on another slide, we can pull people's individual imaging into the programming in some cases. So we can actually see where the lead is positioned as we're programming, and that can help too. So that's a little bit newer and still kind of in the works, but that's a pretty neat thing to have.
Sorry, question. So I'm unilateral. And, my DBS has said, go bilateral.
Mhm.
Dr. Patel, neurosurgeon,
Mhm.
and he does the awake surgery because they want to be able to actually find the spot and see the symptom resolve. But you can't you can't see the symptom resolve on a side that doesn't have a symptom at the time.
Good point. Yeah.
When progression comes around, I think you often looked at it and said, maybe this placement could have been better.
So I'll tell you how they do it then too, and y'all could maybe even weigh in on some of that too, but essentially, yeah. So the question is, they've recommended always doing bilateral, both sides, but if you just have symptoms on one side, how do they know that they're getting it in the right spot on the side that you don't have symptoms? So when they're in there, they use imaging. They do that all ahead of time and really help to guide their pathway. But right, they do a microelectrode recording, so they know that when they've reached that part of the brain. But you're right, they may not see those symptoms resolve immediately, but they can still test side effects. So if they turn it on while you're awake and they're not getting tingling, they're not seeing any kind of side effects, that can help guide them too. It actually can be a good sign a lot of the times if they see tingling. When I'm programming too, if I turn it on and you feel tingling, can be a little bit uncomfortable at first, but often it goes away, and that means they actually got a good spot. If we turn it on and you don't feel any tingling at all, sometimes that's a little bit of a red flag in some cases that it may not be exactly positioned right. So they go by a couple different things. Do y'all have anything to add to that, since y'all are in the surgeries too? No? Okay.
Just one point, I mean, I agree with everything you say. The other point I would add is that the upside, or the downside, I should say, of going through the surgery twice is I think outweighed by using all the data points, NER, intraoperative imaging, testing the side effects, even if you don't have symptoms. I think that any potential problem with that approach are outweighed by having to go through a stage 1 surgery twice. And potentially having 2 batteries, which there are things you can do to just get 1 battery. But
Yeah, I think it's way easier to have them both done at once. We do have some people that a long time ago, they only had one side implanted. Now they've progressed, maybe cognitively things have changed. They're no longer a good candidate to go back and do the other side. So I think it's always, at least with our clinic, we always do both sides unless there's some major reason we shouldn't.
Yep.
Judy?
Are you pretty much saying that even though you don't have symptoms on both sides currently, that you probably will later?
For Parkinson's disease, yes. Not always does it become very bothersome. Some people, it may be subtle on the other side, but over time, that is the natural progression, that it may affect the other side at some point.
So you'll have the lead on both sides for when you need it.
Yes. With essential tremor too, we still do both sides, even though you may have one side that's much worse than the other. Sometimes what has happened is we may just implant on one side, but then that tremor maybe is so well controlled. Now people are saying, well, but I do have a little tremor on the other side. So we still do both sides. The other reason is if someone has a head tremor or a vocal tremor, what we call axial tremor, central, you really need both sides to help control that tremor. Good questions. Okay, we'll keep going. Sorry if I'm putting anybody to sleep, but I think we're having good discussions. Okay, medications and DBS. This is a question we get all the time. We'll start with essential tremor because that's straightforward and simple. But essentially, you most of the time can come off of your tremor medications following DBS. That's one at a time. Starting at initial programming, we slowly come off of them one at a time. So we're not just stopping all of them cold turkey, but that's a huge benefit, I think, because a lot of essential tremor medications can cause sleepiness.
It's also true that you can actually increase.
Well, Parkinson's possibly. I'm just talking about essential tremor. Essential tremor, yes, you can usually come off. For Parkinson's, it depends on the target. Again, so we're back to the subthalamic nucleus, the STN versus GPI. In general, when we're talking about medications with Parkinson's, we can usually cut the medicines in half, typically. Depends on the person. When we're thinking about STN, that's one we can definitely reduce because the stimulation and the medications kind of work together, they're additive. But for GPI, that location in the brain can actually block dyskinesia, those Michael J. Fox wiggle movements. That's usually caused from too much dopamine. If you're blocking that effect, then sometimes you can have the ability to go up on your dopamine a little bit. But usually we tend to go down even with GPI. Right. Yes. Yeah, it can really help block dyskinesia. So Right. They're very quick. Yeah. Yeah. So that's one of the big benefits too. Yes. So we're just talking about the different targets, and Sid was saying that when he had GPI surgery, so his medicine was actually increased because it was helping to block dyskinesia for him. But that is one of the benefits of that target is it can help block dyskinesia. It could work a little bit better for dystonia. So yes. Okay. Did you have anything to add? Okay. Okay. Anything else on that right now? And I already mentioned we don't make any med changes until that initial programming. So that time between the surgery and the initial programming, you'll still take your medicines as normal. And then initial programming, you would show up off of your carbidopa, levodopa, and then we usually will start cutting down and keep making adjustments from there. Okay. All right, so this is a pretty cool slide. This was actually one of our Medtronic patients that I had her initial programming a couple months ago. So it's a little bit hard to see, and y'all can't see my mouse up here. I'll point out on the Zoom screen here too. But up top, I believe this is the left side. They're opposite. So this is actually the left brain. This is the right. But you can see exactly where the lead is placed in the brain target. And the yellow is the stimulation coming on. So that kind of helps guide your programming to tell you which of those 4 leads may be in the best spot. So pretty cool technology. Here, I'll point this out too. Right here, this is the left part of the brain. This is the right. And it helps show the lead exactly in the target. So you can see kind of the second and third are in good location. This patient was actually a generalized dystonia patient, a young girl. And so she's one of the ones that it can help about 50 to 75% of the time with dystonia. You don't always see benefits in programming immediately, So having this imaging was so helpful because we knew exactly which targets were most likely going to help her. So pretty neat technology there. The main question on this slide, of course, is how can DBS affect your speech? So I think when people just Google DBS, this is the one that comes up constantly. So the short answer is yes, but with our advances lately in directional programming, having your imaging, there's several advancements that majority of the time we can get around those stimulation side effects. Everyone's brains are a little different. Some people already have speech issues ahead of time. So everybody's a little different, but the majority of the time we can program around speech changes. And when I say speech changes, usually it's slurred speech. Okay, so what people constantly hear us say in our clinic, so do you remember the phrase we have you say? Today is a sunny day. We constantly have people say that over and over. Today is a sunny day. The S sound. Yeah, the S sound is usually what we can hear a little bit of slurring with. So we'll listen really closely as we're programming. And if we hear it slurring a little bit, we change our programming and we can usually get around that. Any questions about that, the speech? Not usually. Oh, yes. So the question is, and can we turn that light back on? Thank you. It looks like it's kind of dark on me on the Zoom again. Thank you, Damon. Yeah, that's better. Okay, can y'all see me better now? Hopefully. So the question was, can you have temporary speech changes? And are you asking about the initial surgery or after programming? After the surgery? So occasionally after the surgery, but it's pretty rare. And so the thought there would be, was there a tiny small bleed that maybe there was temporary slight change? And I'll talk about bleeds here in a second. It's very rare, but it is possible. If that does happen, the majority of the time it's temporary and it goes away over time. But we can do speech therapy. We can work on that for sure.
Can you see the speech center in the brain?
You on your device, when you're programming, they do have software where you can add it into your programming, but usually kind of directionally where it's located. So for example, with essential tremor, that part of the brain is lateral to where we're programming. So if we are running into speech issues, we can turn off. Remember how we had the 3 broken pieces? We can turn off the lateral component to try to avoid that. So for GPI, it's medial. So just kind of knowing where in the brain you are, you can turn off that piece. So pretty neat that we can do that nowadays. Yeah. Not everyone has the directional ones. There's still ways we can get around it, but that's kind of the newer technology.
Check. Yeah. Are there anything you could attribute to a long-term side effect that you wouldn't be able to turn off from having stimulation over the years?
Like the speech you're referring to?
Talk to someone. That their speech has got worse. Medically due to the DBS, but she got the DBS surgery many years ago. So it would more think that this was just a Parkinson's progression.
Possibly. Yeah. So, right. Yeah. So I'll repeat the question. The question is, can you have side effects that are permanent or lasting, specifically to speech? And usually no. And the big difference there would be, do you turn off the DBS and is there a change? If you turn off DBS and the speech clears up, well, then it's the programming and you can go in and make some changes. But if you turn off the stimulation and there's no change, then it's usually unrelated. If they had DBS several years ago and it's maybe changed a little bit over time, my guess too would be that it was the Parkinson's, especially if it's more of a soft voice.
Let me ask you a question. How many cases
Have I helped you? Oh, gosh, we have, yeah, quite a few. We probably have a couple hundred DBS patients, but trying to think, we probably have a couple every year. And then over the years, we've had some from when Dr. Swallow was back at Scott and White. So we've got a couple. Yeah, sure.
Be that one, sorry.
The question was just how many DBS patients do we have? And probably a couple hundred that we've accumulated over the years. Did I see you raise your hand too, Erin? No? Okay, I thought I saw movement over there. Right. Mhm.
It's the gentleman. Yeah, you sort of making a song and it goes with it. Then it was, yeah. But
Right.
If, you know, as pages, you may need more and more.
Mhm.
You will have the ability to totally reprogram and change away from a speech silence to maybe that would be considered side effect that's DBS related, but we need more treatment.
Right.
So sometimes in the long haul, there's
Mhm. 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 Right. Right. Yeah. Right. Yeah, you're right. Yeah, sometimes over time, yeah, if disease progresses, you do have to change it. Even for essential tremor, we don't always think of that as being progressive, but we have run into sometimes your brain getting used to stimulation. And we'll do ways, maybe we'll have somebody turn it off at night so that their brain gets a rest. There's some ways we can get around that, but sometimes over time, we do have to kind of inch up on the stimulation. And for some people, that may affect their speech occasionally. But I have some people that maybe will set up different groups, and while they're on the phone, they use their speech group. While they're painting, they use their tremor group. And so there's different ways we can combat that. Okay. So we've already kind of touched on this a little bit, and this is also something that really more neurosurgery will talk to you about when you meet with them. But basically how DBS can contribute to a stroke is as they are inserting the lead, there can be some very small blood vessels there as they're going in and introducing that. There's a chance they could puncture one of those. That risk is about 1 to 2%, so pretty low. And when I say 1 to 2%, that's not always a full-fledged stroke. It can even be just a small bleed that doesn't even show up on imaging, kind of like you were saying, Mr. Buckley, just maybe some slight speech changes temporarily, some weakness. Of course, there is the possibility of a full stroke, so that should always be considered, but it's very low. That's even within this percentage here, smaller. But this is something, of course, the neurosurgeon goes through ahead of time with everyone. Any questions about that?
Is that 1 to 2% related to the surgeon himself?
Mm,
Would it have to do with his record?
not necessarily. It can be anyone. But of course, every surgeon, the question is, does that differ between surgeons? And not necessarily. Of course, every surgeon's different and how they do their techniques. And so that there may be a little bit of variability between them, but for the most part, it's 1 to 2, 3% across the board. Not typically. Of course, they watch you. And I think one of the main things that we watch for, oops, let me close this. One of the main things that we watch for too is infection after the surgery. So we've had, for example, we had one patient that is a farmer, and he worked outside even after the surgery, wore hats constantly. He was working in the sun, too much moisture there, it got infected, had to have it explanted. He eventually had it re-implanted. But I think the main thing that we watch for after the surgery is infection.
But the infection, once you're all
Mhm.
healed, you can't have an infection.
It's very, very rare. I don't think I'm trying to think if I've ever seen it years later. It's very, very rare. There would usually have to be something that happens to introduce that. But your risk is mainly as everything is still healing up. So maybe if somebody has a fall, for example, and they injure that even still though, it would be, yeah. It heals down though, and it all scars up. So it's not moving around in there. They tie it down. So were you going to add something, Sid? Okay. Yeah. So pretty rare later on. But of course, if somebody has a stroke before, let's say they've had strokes in the past, your chance is higher for the couple days to weeks after the initial stroke. So they are careful if something does happen, but that's pretty rare to have at all in the first place. So vascular dementia is something separate. That's more over time if you have a lot of little injuries to the brain. So if you've had strokes or high blood pressure, high cholesterol, diabetes, if anything that causes clogged arteries in your heart, that can also cause artery problems in your brain. And so we all, if you see an MRI and you see the words chronic microvascular changes, we all have that, right? We all have things that clog our arteries a little bit, and that happens in the brain. But for some people, if they have those risk factors, they can have more of that. And you can have vascular dementia, or you can have vascular Parkinsonism even.
So does the neurosurgeon do blood work before the surgery to see if you're at risk?
They don't typically need to. Yeah. So your primary care, if they're worried about it, you can talk to your primary care. They can clear you and everything beforehand, but they don't usually need to. Yeah. The question was, do you need blood work from the neurosurgeon ahead of time? And not usually, you don't. Other questions?
This, many reasons you get a really high-end, high-quality with make sure they see all the vasculature and other structure that they want to make sure during surgery. But for DBS, crazy, everything goes into it. There's a lot of reason for that. Big enough is state.
So Damon was just adding to that the MRI that you have ahead of time, that helps them see the vasculature. They do it with contrast so that they can see and help plan the trajectory around those arteries in there. So further helps reduce that risk of a stroke. Okay. We will keep moving. There we go. Okay, so I won't read all these to you necessarily, but that we actually will give all of our DBS patients a handout after their surgery that includes a lot of these. These are just questions I've gotten over the years. And so the big one is you can still get an MRI. Usually that's under certain guidelines. So we have you call us ahead of time or our reps, and they can help arrange an MRI. CT scans and x-rays are perfectly fine. For Bluetooth hearing aids or headphones, sometimes it affects the pairing with, you get a patient programmer so that you can adjust settings on your own within limits. We'll set that up for you. Sometimes Bluetooth will interfere with that a little bit, but does not affect your settings for your device. Won't set off a metal detector. That's good. You usually just tell them you've got a medical device or like a brain pacemaker, because they obviously won't know what DBS is most of the time, but you can tell them you just have a brain pacemaker, and they may wand you down. No issues with the microwave. I know that's a weird question, but I get it all the time. And it can interfere with an EKG and EEG. So usually you'll just turn it off for that. And then you can have a massage, but usually just avoid having your neck adjusted since you've got the wires running down to the battery through there.
What about
Good question. I had somebody ask me that question a while back, actually. So from what I understand, you can, oh yes, the question was, can you weld? Thank you for reminding me. I keep forgetting, Mary Jane. Can you weld with DBS? You can. There's some guidelines, and Candace, I know you sent it to me a while back, but it's basically saying you kind of want to stay, you don't want it to cross the pathway of your DBS wiring. So there's some precautions about it, but from what it sounded like, there haven't really ever been any big issues with it. And the patients that I've had that have welded have not had problems.
Do either your office or the neurosurgeon's office recommend that you get a medical bracelet or something that says you have?
They actually will give you a card that you can keep, and you'll just keep it in your wallet that says, I have a device, and it's got the number on it and everything, so that if there's ever any questions, they can call. But you don't necessarily need a bracelet separate. If you want one that says, I've got Parkinson's, you can, but they'll give you a device card.
And every time you change the battery,
There you go. Every time you change the battery, you get a new card, is what he was saying.
I feel that said it's being replaced.
Mhm. Yes. Yes. So on this slide here, it talks about, we will give everyone, if we know you've got a surgery coming up, we give everybody a handout that has precautions that you'll give to your surgeon. The main thing is electrocautery. So if they're using that during the surgery, you want to turn your device off and then have a family member or a nurse or someone turn it back on directly after. That's the main thing. Mhm.
if when you go in surgery, you
Yes. For Parkinson's patients, yes, you still want to take your medications as you normally would for a surgery. Yep, that's what our sheet talks about too, is every dose should still be on time. That's what Sid was saying. Yes, correct. You should take your own drugs always if you go to the hospital, because they probably don't carry a lot of our drugs. Yes, right. I think that's everything here. Yeah, so I mentioned you'll have that patient programmer that allows you to adjust. It allows you to turn it off too. So you just bring that with you to the hospital. I think that is everything that I've got. So we've got, this is Cooper's our first golden retriever. This is Ellie. We just got her 2 weeks ago. So a little bit sleep deprived still. And this is our Texas movement team. This was from April on Parkinson's Day. I don't think Dr. Spall is in that picture. I'm not sure where he was, but that's the rest of the team. But I'm happy to answer any other questions, and I appreciate y'all's attention. I know it's not always fun to sit and watch everybody talk, but yes. So like the cause of Parkinson's, or
So if you're on a lectin-free diet, you will have minimal Parkinson's.
Symptoms. Yeah, so the question is, does, and I see a question in the chat, I'll answer that next. The question was about diet with Parkinson's. And so this is kind of a longstanding debate. I would say there's no doubt there's gut involvement in Parkinson's, constipation and bloating. It actually starts in the gut a lot of the time, even 20 years before symptoms ever start. So we know the gut is involved. Whether there's a specific diet that Parkinson's patients should be on, there's not necessarily one specifically. The only one that I've seen come up regularly is the Mediterranean diet, just healthy, less red meat, nuts, that kind of thing. And part of that helps with the gut, but it's also shown to help with cognition. But I know there's other things out there. There's supplements out there. There's all kinds of stuff, but a lot of it is kind of comes and goes. Mary Jane?
If there's any questions about nutrition and diet for Parkinson's, we've got a presentation coming up on September 30th in Austin. It's in my newsletter.
Yes,
You can go to
Dr. Krause. Yeah. So there's a topic, there's a presentation coming up on nutrition and Parkinson's this month that Mary Jane sent out information on. And there's a question from the chat that says, how does this affect people diagnosed with Lewy body dementia? So great question. So DBS is done for Parkinson's disease, essential tremor, and some forms of dystonia. When we're talking about it for Parkinson's disease, we have a couple of things that we look for. One is, have you had Parkinson's for at least 4 or 5 years? The main reason for that is because we want to make sure it's Parkinson's itself and not a cousin of Parkinson's. Lewy body dementia is a cousin of Parkinson's. It doesn't always respond to levodopa as well. Therefore, we don't always see as much benefit, and we don't implant people with DBS if they have Lewy body. And part of that goes back to the beginning too. If someone has dementia, they would have a hard time at times participating in the process, being able to give feedback, or especially with Lewy body, they may be more affected by anesthesia. So we would probably, that would definitely be a discussion. If they mainly had problems with tremor, possibly we could consider a thalamic DBS for the tremor, but again, we would have to kind of see where they're at in the process. Typically, we would not implant Lewy body. Mhm,
I've known several people who have diagnosed with heart,
mhm.
who have no response.
Yes. Yes, yes. So great question. Sid was saying, he knows some people that don't have a tremor, and you said don't have a great response to levodopa. Yeah, and don't have a great response to levodopa. So if it's the tremor, sometimes that can be really stubborn, so it may not get better. But a lot of Parkinson's patients don't have a tremor. They may just have slowness and stiffness. That typically still gets better with DBS, but it should get better with levodopa ahead of time. If it doesn't get better with If it doesn't get better with levodopa, oftentimes that makes us think, could this be atypical Parkinsonism, a cousin of Parkinson's? So we would have to do, right, we would have to do some more workup on that. Damon.
What is-
Mhm,
Should be
mhm,
indication that diagnosed sooner.
mhm,
I'm wondering if some recent conferences you've been to or other information that you crossed and sort of your ongoing education,
mhm,
what are you hearing as far as doing DBS earlier? Or I know there's
Mhm.
some studies going on.
Yeah, yeah.
Information.
Yeah. So the question is, when is the right time? Essentially, there's some studies that are showing, that are looking at earlier and earlier DBS being done, mainly in Parkinson's disease. I have seen some studies that they're looking at specifically STN, and there's the thought that it could even slow it down a little bit, the progression. That's still quite a bit under debate, but we are certainly pushing it earlier and earlier. We still want to make sure you're levodopa responsive. We still want to wait at least 4 or 5 years, but we're no longer waiting until we're seeing a lot of ups and downs, a lot of wearing off and dyskinesia. We start trying to have that conversation early so that when it's time, we're not delaying it further. So I do think over the 5 years that I've been in movement disorders, it's definitely moved earlier, and that's the trend. Lots of questions after that. We'll start with you. For essential tremor, the question is that true for essential tremor also? Not as much. We don't have as much of a window of time. And the reason for that is we're not worried about cognition as much. And we don't see as much progression of disease with essential tremor. So we can really do it anytime as long as you're a good surgical candidate. That's really the main thing. Thank you. Yes.
Was it just out of curiosity, what's the youngest and the oldest?
Oh gosh, what is the young? I know the oldest. The oldest we've done is 86.
86.
So, and that again, it just depends. It's not necessarily the age, it's their overall surgical candidacy. Are they healthy? Do they have lung, heart conditions? So we want to make sure they're healthy. Of course, this is elective, but the youngest, I know for a fact we have someone in their 30s that has had a Parkinson's patient.
And the youngest I know that's been diagnosed with Parkinson's is 13.
Oh,
And
Yes, young onset. Yeah.
She is now.
Yeah, so it's probably genetic if she had it that young, most likely. Well, and the other question too would be making sure they don't have Huntington's, because oftentimes Huntington's disease can look like Parkinson's really young. So you'd have to do genetic testing. And then the other thought is dopa responsive dystonia. You want to make sure it's not that too. So a little bit complex, but Mary Jane was saying that she had a 13-year-old diagnosed with Parkinson's. And the youngest we've implanted was in their 30s. The oldest we have done DBS was 86. So just to kind of give a timeline. And I think we had some questions over here too. There can be up to 10 to 15.
Like Parkinson's, isn't any of these?
So here's what I usually tell people. The question is about what does atypical Parkinsonism mean? So Parkinsonism is a symptom that basically just refers to tremor, stiffness, slowness. Parkinsonism is the overarching umbrella. Parkinson's disease is one type of Parkinsonism. Vascular Parkinsonism is a type, Lewy body dementia, progressive supranuclear palsy. There are several types that fit under that umbrella. And there's several different things we distinguish which type of protein accumulates in the brain. So there's a lot that goes on there. But when I say atypical Parkinsonism, I mean it's a cousin of Parkinson's. It's not Parkinson's itself.
Brings up the question of diagnosis.
Mhm.
Principal way of diagnosis.
History and exam. So the question is, how do you essentially diagnose Parkinson's? Mhm. There's not a blood test for Parkinson's. Yeah, so essentially we take the history and exam. The history could be loss of smell, constipation, acting out dreams, your handwriting is small, your voice is soft, and then we see tremor, stiffness, slowness. And those are the main ways it's diagnosed. Over time, we also look at how you respond to medicines. That's another big one. Are you responsive to dopamine? But there is a lot that goes into that. We've got a DAT scan that looks at dopamine levels in the brain. There's a new skin biopsy that's only been around for a year or two. But even those, they don't tell you what type of Parkinsonism. Exactly, the alpha-synuclein skin test. That's the protein that accumulates in the brain with Parkinson's. Yeah, so it's pretty new still. There is a study that we're a part of right now, actually, that's looking at differentiating between Parkinson's, multiple system atrophy, and Lewy body. So at some point, that would be lovely if we had that. But right now, it doesn't differentiate the types. It just tells us, yes, you've got a dopamine deficiency or you have alpha-synuclein. No, yeah. So, and I know, sorry to all the essential tremor people, this is a lot of Parkinson's questions, but I think it's still good to talk about. Any questions in the chat, feel free to type them in. I think we've still got a couple others here.
I experienced. I'd get in the shower and I couldn't feel it. I had no feeling in my head. That went on for about 2. Okay.
Yeah, disrupted the nerves in there some. So he was saying he went through. So he was saying for essential tremor, he had DBS, and because some of the nerves are disrupted in here, there was some numbness around here. And you can have tiny little bumps on your head where the leads are placed, but I can't see them. So they hide them. Yes. Oh, yes, you can unmute yourself to ask questions too. I have not seen any others come through the chat. Can y'all think of any other questions? One more?
There's the decision. Say, what? Okay, we can do it this way. Do they customize the process at all by saying, okay, you know, the MBS said go use GPI. Do they go, okay, well, is this an essential tremor or is this Parkinson's or what's Parkinson's like? And if so, they will turn the electrode this way, or do they
No, they don't, because the targets are not massive. It depends on the target, but really you want that right smack in the middle, regardless of your condition. But essential tremor is only the thalamus, VIM. Parkinson's is going to be GPI or STN, unless you're only treating the tremor, but you don't necessarily move it deeper or rotate it. You want it right smack in the middle of the target for the best programming. Don't see any other questions here. I think we are done. Oh, one more. Good question. The question is, what made me go into this? Let's see. Well, starting back a while ago, I had a friend that was a PA. And so early on, I knew I wanted to be a PA, and I chose to go into that. Just versus med school, you have more flexibility. You can change different specialties, and I wanted that work-life balance with family. So that's why I chose PA. But movement disorders, I actually, as I was graduating, was connected with Dr. Swallow through one of his patients at their church. And I shadowed him for about 3 months before I started, just to make sure I liked it and he liked me, and the rest was history. I just kind of fell in love with it. I think there's not very many areas of medicine where you can do something like this or start a medicine and see an amazing change within a matter of minutes. I mean, it is pretty neat to see.
Right on that same topic, were you trained in DBS in school, or
Good
under
question.
Dr. Swallow?
Yeah, so the question is, was I trained on DBS in school? So PA school itself, you have 2.5 years and you're trained in everything. You have several different rotations, whether it's surgery, emergency medicine, pediatrics, you have everything. And then outside of school, if you go into a specialty, you're trained on the job. So before I even started, I did a whole bunch of training. I started learning DBS. They have a bunch of trainings you can go to. So I learned from Dr. Swallow, I learned from Medtronic and Abbott, all the different systems. That was even before Boston really got out there, I think. So, but it was more kind of learning after the fact. But nowadays there's a lot of programs, and I've actually been a part of a lot of programs helping to train APPs, PAs, and nurse practitioners. And they're starting a movement disorder certification so that new APPs can get trained on it as they're coming out. So you should never see an APP that has not been trained. There's too much out there nowadays. A nurse practitioner, essentially they're the same. So we both see patients, we both prescribe, we can both order therapy, we can both program. The difference is the background, that usually nurse practitioners, they're nurses before they go to nurse practitioner school. I was an EMT. So I may be EMT, they may be a scribe, they may be a tech. So it's just different backgrounds. Yes, go ahead. Okay.
Just, and I'm sure it's different for everyone or
Mm-hmm.
whatever, but say for example, she decided she wanted to go for this.
Mm-hmm.
How long does the process take? Like
Mm-hmm.
from that beginning portion to going through and having
Mm-hmm.
everything?
Yeah. So usually when we send, if you've had the neuropsych testing done, we send the referral to neurosurgery. You can have that surgery scheduled within the next couple of months. And then the initial programming. So I would say 3 to 4 months once you get that process rolling. Here in the Austin area right now, we've had some trouble getting neuropsychology done in a timely manner. There's a shortage in the area. They're scheduling sometimes 6 months out. So if you know you want to have DBS done, get that in the works sooner rather than later, just because neuropsych testing is taking a little bit longer than we would like.
That being said, then say for example, it might be like in the Austin area, do y'all work with other kind of close areas?
Mm-hmm. So we used to have an office up in Waco. So we definitely have several that we work with up there, but we also have a number of patients that come from Abilene, and there's some neuropsychologists there. So yeah, we have some connections elsewhere too. Mm-hmm. Okay. I think we've exhausted all the questions. Thank you all for your attention here too. And thank you so much. I love coming to these.
Thank you.
Thank you.
Thank you for that. I'll send you another a long list of questions. Right. Before we did this, I don't know how many questions I sent you. And she was so kind to us, and months ago, I talked to Meredith, she said, I'm working on it, I'm working on it. So that was very nice. We're so glad that all of you could join us today. We do meet the third Wednesday of every month, 2 o'clock right here. Next month, we're having a Q&A session with professional people to help answer questions. So please come and get cookies and do the making friends part of our mantra. So thank you very much. See you next week, month. Oh, yes, and don't forget, tomorrow is the big meeting in the gym. And Mary Beth, Jane would, I've known her, what, 13 years? I should know. Anyway, thanks for coming. See you next time.
Yeah.
I'm sorry.
No, don't worry. Bye, guys. Good to see you, Cecil. Good to see you. Okay. Let's see.